So I'm going to take you on a whistle-stop tour of how all this evolved and how the evidence came about. So this is really the whole change in the way that we treat, and this is thinking about metastatic melanoma in the last 10 years, where we've gone from pretty much nothing to having all these various different options available to us. We have these two cohorts of types of treatment, the immunotherapy, the BRAF-targeted therapy for the BRAF mutant patients, and we're just focusing here on the immunotherapy side of that slide. And just to show you, we have these different drugs. So Ipilimumab was the first drug that came into the clinic, and then we've moved on to these other drugs called the anti-PD-1 antibodies, nivolumab and pembrolizumab, and then the combination. And all these are available to us in the UK, which is more so than some of our European colleagues have access to, which is interesting. And the story started with a randomized trial. Again, all this has happened through the conduct of an enormous number of clinical trials. And we wouldn't be where we are now without that evidence being generated through that program. And that's through patients taking part to develop this evidence base. So I support everything that Bruce has been saying. So the first trial with Ipilimumab, as Simon said, this is a drug that takes the brake off the immune system. So we're actually harnessing the natural immunity within the individual. And the first trial compared Ipilimumab to an equivalent of a placebo. And this is the kind of survival curve that you've seen before. And the top curve represents Ipilimumab, and the red one is the standard arm. And although you can see that this is a survival curve, 100% of patients are alive at the beginning of the trial, you can see that a lot of patients unfortunately die during the course of that trial. And they do on the Ipilimumab arm. But what was interesting and what really caught the imagination and the understanding of the scientists and the clinicians at the time is that these curves flatten off. And so it's the difference here between these two curves that's really important. Normally, we'd see all these curves just going straight down like that. Basically, virtually all patients would die of metastatic melanoma. Now, there were about 20% of patients who actually were living alongside their disease or beyond. And with long-term follow-up, again, this was consistent data, and we've seen it with real-world data, that actually with Ipilimumab you see this plateau, and this is what's characteristic of these checkpoint inhibitors, that unfortunately, although only the minority will get onto this plateau, if you get onto the plateau, you may even one day be able to, we may be using the word cure, but it's a remission of a durable response. So that's what we're excited about. And what we're trying to do is actually increase the proportion of patients who get into this plateau. Now, what we also saw when you're in drug development work, not only are you interested in looking at efficacy, but all these drugs have other effects in the body, and this is the toxicity profile. And part of the job of oncologists is to learn how to manage toxicity, to understand its mechanism and how we deal with it. And there is always an interest to know, is it in itself a relevant marker of something? So with Ipilimumab, we saw a variety of toxicities we'd never seen before with cytotoxic chemotherapy. And what we have come to understand is that this is, again, because you're releasing this immune response, you're getting inflammation of multiple body systems. So it's a relatively non-specific effect, and any body system can get this inflammatory process. But the common ones that were seen on a frequent basis up here were the skin, diarrhea or colitis, hormone changes, so people developing thyroiditis and then becoming hypothyroid, pituitary dysfunction, liver dysfunction, pneumonitis, or anything with an itis on the end of it, conjunctivitis, thyroiditis, all these kind of itises, they all represent inflammation. And although these are the common ones, there are rarer ones which are important. The very, very first patient we ever treated developed thrombocytopenia, and he sat on the ward with 5 platelets for 10 days, which was pretty scary. But he did get better. Uveitis, Guillain-Barré, so you can get inflammation of the nervous system, and that can put people on ITU. So these are really quite serious side effects. But we now refer to these as the immune-related adverse events, and we're always interested to collect that and manage that effectively. So the most common, just sort of depicted here in a little diagram, but in particular, there were some treatment-related deaths, and they're related usually to colitis and the unfortunate situations, if that's not managed, picked up quickly and managed effectively, you can get colonic perforation, and there are occasional deaths with this drug. So these are serious issues. There are patterns of when to look for these toxicities, and whereas with cytotoxic chemotherapy, those toxicities tend to happen whilst you're actually having treatment. They can happen whilst you're having immunotherapy, but with Ipilimumab, the duration of treatment was actually 12 weeks, and we were seeing toxicity after the 12 weeks, which goes back to the point we talked about earlier today about memory cells and the fact that you can still have the effects of your immunotherapy even after you've had the drug given and you've stopped treatment. So again, we do need to keep an eye on patients beyond their treatment exposure time because of the other toxicities that can occur later on. And people did ask the question then, was toxicity a marker of response to Ipilimumab? But I think the general consensus, looking at all the data, and we did some real-world analysis of patients treated in the UK, we didn't really see a clear correlation. So it was interesting, but it was kind of put aside at the time as not being that important as a biomarker of response. And then we got into the world of the PD-1 antibodies that came later, just convincing you that the data here shows the superiority of PD-1 monotherapy over a standard of care. I'm going to keep thinking which button to press here. So this was compared to Ipilimumab in this trial, and this was compared to dacarbazine in the other. And in each occasion, you can see the anti-PD-1 monotherapy was superior. And again, the same question was asked. And toxicity-wise, interestingly, pembrolizumab and nivolumab are much better tolerated than Ipilimumab. So if you look at the antibody system frequency of toxicity for CTLA-4, so at Ipilimumab, it's around 27% of people are going to get a severe, when I say 3-4, that's a severe or life-threatening toxicity. But only 16%, so maybe half the number, are going to have such a problem with the PD-1 antibody, which is great. So we're bringing in a more effective drug, which is actually better tolerated. That's a big plus. So that's a good thing. And again, the question was asked about whether there was a correlation. And this has been far more controversial. So there are a number of reports that have suggested either way in metastatic melanoma. And just recently, at the meeting that Palam referred to at ASCO this year, there were 2 papers looking at the impact of toxicity in the adjuvant setting, each reporting different outcomes for each of the 2 drugs. So again, this is it's not at all clear as to whether it is a marker of efficacy for monotherapy. But even so, as I've said there, the PD-1 antibodies are much better tolerated than Ipilimumab anyway, so it's a much less of an issue. However, we then need to talk about the combination Ipi-Nivo, which was tested in this 3-arm trial. It's a very famous trial, and we refer to it a lot in our field. And this compared the combination Ipi-Nivo with Nivo and with Ipi alone. And we see here the highest response rate is with the combination, so 58% versus 44% versus 19%. And this is the progression-free survival, so how long people live without recurrence of their disease. Now here, whoops, let's go back. Here, what's interesting is you see a lot of patients all progressing quite early, and then you again see these plateaus. And we had, I guess, hoped that there would be a bigger difference. So this is the Ipilimumab progression-free survival curve. This is with Nivo, and this is with Ipi-Nivo. And there is difference between these two, but it's nowhere near the difference of those two. So it's a difference, but it's not massive. And then with overall survival, we looked at this first thing this morning. Again, you see an incremental gain between the two, but it isn't as massive as possibly I think we had hoped for in our community. Because alongside the survival is the toxicity, and here there's a 3-fold increase in severe life-threatening toxicity with the combination. What else can we learn about that? Well, we can see, again, that all the same sort of systems are involved that we've seen before. What does it mean in terms of our clinical practice? Well, in terms of actually talking to patients, what to expect, I kind of talk to patients and say that actually if you have the single agent, you've probably got about a 1 in 10 chance of being admitted to hospital with a toxicity, probably almost a 1 in 2 chance of having a hospital admission for toxicity with the combination. So that's the kind of thing we talk to patients about. And the frequency, the timing of those toxicities, again, reflect a little bit about what we saw with the Ipilimumab on its own. And a lot of the activity, a lot of the complex toxicity all occurs within this first 12 weeks. And that's when people actually literally have the combination. So it's only for the first 12 weeks do the patients actually get both drugs at the same time every 3 weeks, and then they go down onto the monotherapy. So it's getting people through this first 12 weeks, which is the tricky bit. We saw that with the combination, people are more likely to get more than one body system affected by treatment. And this was some really interesting information. So I'm just going to lead you through this. This is what we call I was going to call it a swimmer plot. And basically, each of these lines represents an individual patient on treatment over time. And when it's blue, they're on treatment. And when it's red, they're off treatment. And if there's an arrow at the end, it means that they're still well. And if it comes to an end, then some of these patients will have died, unfortunately. But the important bit is that you can see that a lot of the patients who go from blue to red still have arrows, so they're still in an ongoing response. And a lot of the patients stop because of toxicity with the combination. So in that main trial, the median number of doses, in fact, was 4. So most patients got that 12 weeks, but that was it. Most of them actually didn't get on to the monotherapy because of toxicity. 68% of patients who discontinued the treatment because of toxicity remained in long-term response. So these are the patients we talked about earlier, where they've had toxicity and they are no longer having drug, but they're continuing to respond. So does that tell us that actually their toxicity is a good thing, that at least we can reassure patients, because patients don't like to stop treatment, but actually maybe don't worry about the fact that we're stopping treatment because you probably got that immune response that is ongoing and you don't actually need any more drug. And I remind you, when we talked earlier, that a lot of this duration of treatment has been driven by pharma rather than biology. So just to demonstrate quickly, a patient of ours, again, a young woman who had a primary melanoma back in 2015. She had regional recurrence, and then she went on to develop early lung metastases. And we talked to her about her treatment options, and she elected to go for the combination. And after her second cycle, she mentioned she'd got a bit of tiredness, but then started to develop a rash and a colitis with which she was admitted. And she had a pretty torrid time in hospital. She had high doses of steroids. During that time, she then developed hepatitis, and her thyroid function tests came back and they were abnormal. So she's now up to 4 body systems being affected by her treatment. And meanwhile, she's struggling on the ward, unable to eat or drink properly, so she had to be artificially fed. She had high doses of steroids. She had a subsequent drug called Infliximab to try and harness that, to suppress the immune response that was going on. We went on to another drug called vedolizumab. She was so unwell, but ultimately her symptoms settled and we were able to get her home. And she came back about a month later having developed a really nasty polyarthritis. So yet another body system affected. But that lady, that's 2017, we're now in 2019 and she's in a complete response. She has to manage her arthritic problems, but she's otherwise normal and she's just relocated to live in Spain. So for her, was it worth it? She would say yes. So that's the kind of things that we're dealing with in clinic. And there are a lot of questions that are people kind of coming back, when people have had toxicity, maybe not quite that bad. I don't think anybody would retreat that lady, but if somebody has had, say, for example, biochemical hepatitis, which is a change in their liver blood test, but not necessarily any clinical changes, would you retreat those patients when those symptoms have resolved? And I think this kind of data suggests that probably it's worth holding back to see whether actually, there's a lady I was talking to earlier, whether 1 course, 2 courses, 3 courses of combination therapy is actually enough. And if you think about the neoadjuvant data that Paula referred to earlier, where 2 cycles of neoadjuvant therapy has enabled people to remain disease-free after their surgery, then I think this is a very powerful combination, and toxicity probably is a useful marker for us in some patients. Toxicity does need to be managed carefully. We do have international guidelines and we do have multiple people available to help us manage those toxicities to keep people safe. So that's probably sort of a summary of, yes, with the combination, there's a very high chance of toxicity, but there's also a very significant chance of response in those patients who get the toxicity. That doesn't mean we have 1 or 2 patients who are in clinic thinking, oh no, I'm not getting any toxicity, does that mean I'm not benefiting? And that isn't the case. It isn't that clear cut, but it's something that we are very interested in understanding. And also, therefore, trying to understand it from a mechanistic way by beginning to do systematic studies, collecting samples from patients who both do and don't have toxicity so that we can understand the biology and the mechanisms behind it. And there are a number of different studies that are setting up. There's one in Birmingham, we've got a study in Liverpool and so on. And I think as a national group, we need to work collectively to try and combine forces to answer these questions. So many of our patients now are kindly offering various samples, tumour blood, and very interested in bugs in your poo. So the microbiome is very trendy at the moment. So just to summarise, clearly these treatments are very effective. Still, we need more people to be benefiting. Toxicity is common. And at least for the combination, it is an interesting potential biomarker of response. So I'm going to leave it there.